Welcome everyone to the webinar that we're presenting tonight. Thanks for joining us. My name is Jeff Wera, and we're going to be talking about why do your fingers and hands hurt. We're going to be exploring two very common causes of hand and finger pain tonight. So first off, welcome. You are all muted. So if you are going to have any questions, please feel free to type those questions, comments, or any technical difficulties in the chat box. Our questions will be answered at the end of the presentation. This is being recorded and you will receive a follow-up link within 1 to 2 days so you can access this. So disclosures, I have none. And a little bit about myself, I'm a Northern Kentucky native. I grew up in Northern Kentucky and I went to Beechwood High School. I then went to undergraduate education at William & Mary in Virginia. I played baseball down there, and that's where I met my wife, Megan, who you can see in the bottom right screen. She played soccer and I played baseball. I then went to medical school at University of Louisville, and then I completed my orthopedic surgery residency at Temple University Hospital in North Philadelphia, and then finished my training doing a hand and upper extremity fellowship at the University of Pittsburgh Medical Center. And so I'm specializing in hand, wrist, and elbow, and then some general trauma as well too. So again, that's my wife, that's our dog Hutch. And so now on to the presentation. So carpal tunnel syndrome, we're gonna review the anatomy, what causes it, or the etiologies, symptoms you may have, how do we diagnose it, and then ultimately what matters is the treatment. So briefly, the carpal tunnel anatomy, this is gonna be focusing on right at that wrist crease, right where your hand meets your forearm. So the carpal tunnel is essentially a box. 3 sides of that box is made of bone, and then the roof of it is the transverse carpal ligament. So the space is set, the bones don't really move. The transverse carpal ligament's very, very thick. And so if there's any kind of changes within that, whether there's synovium or the tissue around tendons, if there's any kind of fat can get bigger, smaller throughout our life, or if there's any inflammation within that, or if there's any swelling within the nerve, that can cause the symptoms of carpal tunnel syndrome. So what causes carpal tunnel syndrome? That's a very, very common question that we get. And the overwhelming majority of cases are caused by, it's tough to say, idiopathic is what we would say. So it's a very, very common condition, but the majority of the time it just is something that happens. Other causes of it, though, traumatic incidence is quite high with distal radius fractures, depending on how bad the distal radius or the wrist fracture could be. And that's because of the swelling, the blood associated with breaking bones can actually put pressure on the nerve and cause the symptoms of carpal tunnel. Inflammatory conditions, such as rheumatoid arthritis and gout, can also contribute to carpal tunnel. And then metabolic imbalances, whether it's diabetes in general, can actually affect the nerve health by damaging the small blood vessels that will actually give nutrients to the nerves. And then thyroid disorders can also affect it as well too. And then lastly, if you're presenting with these symptoms at a very young age, pregnancy can affect the fluid changes and then fluid balances and cause increased pressure within the carpal tunnel as well too. So what are some of the symptoms that you may be experiencing? Paresthesias, dysesthesias, that's just a fancy term for that feeling that you get, that is that painful discomfort, numbness, tingling that you can't really put a word to. That's what the dysesthesias are. Pain is a very common complaint. Weakness, difficulty with finger dexterity, grasping objects, nighttime, numbness and tingling that wakes you up at night is an extremely common complaint that we hear. Positional numbness and tingling, such as driving long distances with your wrist extended, that can cause the symptoms. And then at nighttime, a lot of people sleep with their wrists flexed, and that can also increase the pressure within the carpal tunnel, causing the symptoms. Again, dexterity issues, and then swelling and pressure. And then also you can have some neck and shoulder pain too. And so a lot of times we see patients that have seen a neck surgeon or a shoulder surgeon. And sometimes we send our patients to neck surgeons or shoulder surgeons to try to get a better idea if the symptoms you're having are coming from the neck or from the wrist. And sometimes it can be a combination of both that are causing the symptoms. So how do we diagnose carpal tunnel syndrome? A lot of the times we're able to diagnose it on physical examination and what you're telling us your symptoms are. So if you're having any atrophy, as you can see in the right top right picture, that's the thumb thenar eminence that you can see. It's what we would call wasted away, or there's atrophy or decreased muscle mass. And so the nerve comes by the wrist crease and gives off a branch to your thumb muscles. And so for a long-standing carpal tunnel syndrome, that can affect the communication from the nerve to the muscle, and then the muscle's not getting the communication, and so then it stops working and it starts to waste away. That would be very concerning if you have that. Weakness on strength testing is something that's very common that we see on a physical exam. A Tinel sign in the bottom right-hand picture is when we basically tap right on the nerve, and if the nerve is irritated and has been compressed for some time, tapping on that nerve can send jolts or shock-like sensations into the fingertips. And the fingers that are affected by carpal tunnel are the thumb, the index finger, the middle finger, and then half of the ring finger. And then another common physical exam maneuver that we do is just by simply flexing the wrist and putting pressure on that nerve. If the nerve's already compressed to begin with, us doing that can just exacerbate or make that worse and then recreate your symptoms. But ultimately, the gold standard is obtaining an electrodiagnostic study or nerve conduction study. The reason why this is important is because you can have more than one thing going on in your hand and wrist and arm. Your nerves basically come from your neck and travel down your arm to your wrist and then to your fingers. And so there can be compression along many different locations on the course of the nerve. So the other important aspect, it will tell us how severe is your carpal tunnel. So if your carpal tunnel has been long-standing for many, many years and it's causing motor changes or wasting away of the muscles, that would make us want to intervene more quickly. And we can give you prognosis as to what to expect your recovery to be. And then also peripheral neuropathy. You can have other nerve compressions. It can also tell us if there's radiculopathy or compression of the nerve at the neck. And so a carpal tunnel release or an injection or bracing might not help that. And so that helps guide treatment as well too. So how do we treat carpal tunnel? So early on, or if it's mild, the first thing that we would try is wrist splinting. And the reason being is because if you flex your wrist at nighttime, you're asleep and you cannot tell until it's too late when it's causing you to wake up and having to shake out your hands that the nerve's compressed. And so early on, if we can just basically sleep with a better position of your wrist, that takes a lot of the pressure off your nerve. Think about it. You're asleep 6 to 8 hours a night. And so that's between 25 and 33% of the day. So by having good sleep hygiene and good sleep wrist positioning during sleep, that kind of sets you up for the rest of the day, which it takes more to irritate that nerve. And again, another thing to consider is lumbrical stretching. So different finger stretching exercise programs have actually been demonstrated to be equally as effective to operative management in early mild carpal tunnel syndrome. So splinting plus lumbrical stretching. And then an additional consideration, depending on your nerve complaints or your symptoms, we do consider injections as well too. And the injection is numbing medication or lidocaine, as well as an anti-inflammatory steroid medication that decreases the swelling around that nerve. So ultimately, if all conservative treatment fails and you're still having symptoms, or if you get the nerve conduction study and we see that you're having motor changes or muscle changes, and we're concerned by that, then sometimes we actually do jump to surgery off the bat, because essentially what is happening is your nerve is being suffocated, not getting the blood flow, not conveying the signal to the muscles or the fingertips and sensation. And so then you worry about permanent damage. And so an open release is a surgery that involves approximately a 3-inch incision right over the base of your hand between the hypothenar and the thenar eminence, basically right where the valley of your hand is. We basically make an incision there, and we take the pressure off the nerve. So it's a 5-minute procedure. A lot of times we can do it under local anesthesia only, so you're awake if you want to be. You can eat that morning. You can drive yourself to surgery, and we take care of it right there. If you're a little apprehensive, a little nervous, some patients do request that they get some light sedation. And so that's just a 5 to 10 minute nap. We place stitches there. Typically, you keep the postoperative dressing on for approximately 72 hours, and we just ask that you keep that dry for that time being. And then you would take that off and put a Band-Aid on over top of that. You can get your incision wet. You just don't want to soak it, and we ask that you don't rub it. And then we would take the stitches out between 7 and 14 days, on average about 10 days. So next is trigger finger. So again, we're going to review the anatomy, the causes, the symptoms, diagnosis, and treatment. And so the picture to the right is a pretty classic picture of a trigger finger, or when people come into the office and they say, hey, my finger is really, really hurting. It catches like this, and then I have to basically pop open my finger, or I have to take my other hand and open my finger. And so we'll get to that here in a second. So first thing we need to talk about is the anatomy of the finger. So your muscles are attached to tendons, and then those tendons attach into the bone, and that allows us to move our fingers. And so the pulley system is basically a tunnel system through which these tendons travel. And so the issue with trigger fingers is one of two causes. It's whether there's inflammation around the tendon, which then it gets caught underneath of the A1 pulley, which is in blue. That is the culprit of trigger fingers. Or the tunnel system can become fibrotic or narrowed, which does not allow the tendon to glide as smoothly. So it's kind of the chicken or the egg argument. And it's tough to say which one is truly the cause, but regardless, the end result is triggering or catching, clicking, and locking of the finger. So what causes trigger finger? Well, it's one of the most common things we see. The general population has a 2 to a 3% risk over the course of the lifetime to having at least one trigger finger. If you're diabetic, you have an even higher risk of this, and that's 10 to 20% of the diabetic population will experience trigger finger. Women are 6 times more likely than men. And then it's also very, very common to see both trigger finger and carpal tunnel syndrome together. And a lot of times we take care of both of those at the same time, actually. Gout can be associated with trigger finger. Any kind of deposition of crystals or gouty crystals into the tendon can cause it. Renal disease, hypothyroidism, and then again, rheumatologic diseases as well too. So how do we diagnose trigger finger? Again, it's on physical exam. A lot of people will complain of pain at the A1 pulley, right? Basically where the finger meets the palm. And people will report clicking or catching or even locking when the finger gets stuck in the palm. And then this is obviously painful, so people complain of pain. And the way we grade it is 1 is the least worst, and then grade 4 is the most severe. Grade 1 is you just have pain at the palm and tenderness when we press on the A1 pulley. There's no clicking or catching at that point, but it can progress to catching of the joint as you make a fist, catching of the finger as you make a fist. Grade 3 is when there's actual locking associated with that, and you have to pull the finger out straight. And then grade 4 is the most severe, and that's when the finger is actually stuck. It can't move. And that's obviously pretty severe. So how do we treat trigger fingers? Splinting can help, less reliable than injections. Therapy is also a possibility for tendon gliding exercises to try to increase the gliding ability of the tendon. But pretty classically, trigger fingers are treated with injections. Again, the same combination of drugs with lidocaine, the enema medication, as well as a steroid medication to decrease the swelling around that tendon sheath. And so at the first visit, if you're having significant triggering or pain there, we would consider an injection. And then sometimes a second injection is required too. I compare it to if you have a big bonfire and you take a 5-gallon bucket of water and you pour it on the bonfire and you basically get rid of the majority of the flames, but you still have those simmering embers laying around. Sometimes a second injection can really help put those flames or the symptoms out. So sometimes a second injection is required. However, if you don't get better, if you're still having symptoms after injection and non-operative management, then we would consider surgery. And so that is a picture of a postoperative patient with a small incision of approximately, it's about 1.5 inches, 2 inches. And so we basically get down to the tunnel, and then we basically just release the tight tunnel around the tendon. And again, this is done under local anesthesia. So you're awake and you're actually participating, because we want to make sure that we get all of the compression there. So after we release the A1 pulley or the tunnel, I have you make a fist, and I put my finger right on the incision and say, hey, make a fist. And then I feel for any kind of clicking or catching. And if there's no more catching, then we're finished. And if there is some clicking, then I look for any more compression, and then we release it. So again, sutures stay in for approximately 10 days. Dressing would stay on for approximately 72 hours. And then you would put a Band-Aid over top of the incision until you see us back. So just to kind of reiterate, postoperative expectations, soft dressings on for 72 hours. Under local anesthesia, you can actually drive yourself home. You can have your morning cup of coffee. Stitches stay in for approximately 10 days. And then after the stitches come out and we ask you that you do some scar massages to help with the scar tissue, so there's no adhesions, and it helps with the appearance of the scar as well too. And then we typically see patients one postoperative visit. I'm happy to see patients as frequent as they need to in the postoperative setting, whether it needs to be questions that need to be answered, or if there's any concerns or anything like that. But typically, the majority of patients have one postoperative visit. I'll call you the day after surgery to see if you have any questions, and then you're on your way back to the things that you love to do. So I just wanted to say thank you so much for joining us tonight. I know it was a quick talk, but I do appreciate your time and taking time out of your schedule to see us. If you have any questions, please do not hesitate to call me or my office. I see patients in Florence office at off of US 42, and then also at the NKU location in Highland Heights. And so I see that there's some questions that are popping up, and I will pull those up and we will start answering them. Let's see. First question, very good question. Is carpal tunnel surgery a one-time fix, or would I need regular treatments? Great question. So once we release the pressure off the nerve, the majority of time, it's one and done. You get it taken care of. And once the pressure is alleviated, that transverse carpal ligament is what we're releasing. A lot of times I will kind of scar back over. However, that will scar at an increased length, so the pressure won't be there. However, over time, you can redevelop carpal tunnel syndrome, not very commonly though. I would, and if that does occur, then we would kind of go down the same kind of treatment algorithm, but that's typically years later if that were to occur, but it's uncommon. Next question, will my trigger finger come back on the same finger? Again, it could, but unlikely. If the pulley system, the A1 pulley or that tunnel is released adequately at the time of the first surgery, then it should be, again, one and done. You can develop some scar tissue, which could cause some symptomatic issues for you. And that's one of the reasons why we have you do the scar massage. Next question. I had PRP injections on my knee. Would these injections help my hand? There's not much in the way of research that has been done for PRP injections into the hand. PRP is good for regenerative purposes. And the reason why we treat carpal tunnel syndrome and trigger finger the way we do is because we don't, it's a compression issue. So basically it's a space issue. There's not enough space for the tendon to glide. There's not enough space for the nerve to glide in. And so PRP injections would not help the same way that they do for knees or shoulders. And it's really just relieving the pressure is what we're going after. How can I prevent trigger finger? Is that possible? There's really, no, if it's going to happen, it's going to happen. The best way to control it, though, would be by good diabetic control, sugar control, making sure that if you have gout, paying close attention to that, and making sure the other medical issues that you may have that could contribute to trigger fingers are taken care of. But no, it's just a very, very common thing that we see. And there's really no preventative issues or preventative things that you can do to prevent it. So When can I use my hand after surgery? Great question. So we actually, I frequently tell patients, move your fingers as soon as you can after surgery, because we don't want that scar formation forming. It's a delicate balance between getting the incision to heal and making sure that we're moving our fingers, because stiff fingers are very, very painful. And so when can you use your hand after surgery? It's whenever you're comfortable. The sooner the better. So I would not allow you to lift heavy objects. I wouldn't want you to go doing heavy lifting and exercise or weightlifting or anything like that. But on basically activities of daily living, grocery shopping, cooking, stuff like that, take it easy, because we want the incision to heal, but you can return back to normal life relatively soon, as long as you're able to tolerate the things you do. Do I treat Dupuytren's? Yes, I do. So I'm happy to see you if you have any questions regarding that. That's a great question, because sometimes a locked trigger finger can look like Dupuytren's, and sometimes people think that they have a trigger finger and it's actually Dupuytren's. And so just to touch base quickly about Dupuytren's, basically the palmar fascia, the very, very thick area of tissue underneath of your skin, is what the issue is with Dupuytren's, and that causes contractures where your fingers get bent and you cannot passively, meaning you cannot use your other hand to straighten them. And so, yes, I would be happy to see you if you have any issues with Dupuytren's disease. Let's see, with trigger finger, how far apart can cortisone shots be given? Great question. So let me answer that in two different ways. So typically, the way that I manage this is I'd give you an injection. If I first saw you and you're having issues with a trigger finger, one shot, and then I say, come back and see me in 3 weeks. If you're better in 3 weeks, cancel the appointment. But a lot of times what I see is patients are like, man, I feel really, really good. I'm about 75% better. I still have a little bit of clicking, a little bit of catching. And then we would try that second injection, kind of like putting out those simmering embers, is kind of what I referenced before. But so 3 weeks, but after 2 injections, I would either, if it gets better after 2 injections, great. If not, then we would proceed with surgery. And then the second part to that question, or to my answer, would be that we would wait 6 weeks from the last injection to surgery, because there's research that would suggest that there's increased wound healing issues as well as infection if you have surgery before then. So. What repetitive activities are likely to cause trigger finger and or carpal tunnel syndrome? So if you look in the research or the literature, the one common issue is repetitive vibratory sensations have been associated with carpal tunnel. There's been no evidence to prove or support that increased use on the computer or computer use or desk work is associated with it. However, I do see that a lot, and I do think that it probably does contribute to it. But so it's repetitive use, vibratory sensations that you're commonly seeing as associated with the activities that are associated with carpal tunnel and trigger finger. What would cause knots on my joints? They are very painful. Would arthritis be common with carpal tunnel? Great question. So painful knots on your joints could absolutely, most likely be, depending on which joints of your fingers, could be associated with either osteoarthritis, which is just the wearing of the cartilage, just using your fingers, and then with the common wear and tear, or rheumatoid arthritis. If that's at your knuckle joints, that could be a different issue. And so, yes, arthritis in your hands can be common with carpal tunnel syndrome. Absolutely. So that looks like those are all the questions. Very good questions. I appreciate the questions, and I greatly appreciate you all joining us tonight. I'm happy to see you if you have any questions regarding trigger fingers, carpal tunnel syndrome, anything to do with your fingers, wrist, hand, elbow, Dupuytren's. So again, we will be sending out this presentation, and thank you again for joining us.